Marcondes, thank you so very much again for joining us. And you've got your audience here ready to listen, sir. Thank you.
Perfect. Thank you so much. I'm trying I mean, give a presentation, I think in the next like maybe 20 minutes or so, briefly covering the main topics, and then we're gonna have some time later on to address the Q&A. So please feel free to ask me questions later on. Well, so the idea here is to cover, two main topics. So I'm going to cover briefly about neuroimaging, and then I'm going to talk a little bit about neuromodulation and how these two, techniques and approaches can really help us to understand the disease and hopefully help us to design and to develop new therapies for HSP. Well, I'm pretty sure that many of you are pretty familiar with the disease and the key concepts, but I decided to begin by bringing some very basic concepts that I think might be helpful for some of you. And I'd like to begin by bringing the definition. So what is HSP in the end? So the first idea that I'd like to convey here is that it's not a disease, actually. It's actually a group of diseases that share three main features. So paraplegia means leg weakness, spastic or spasticity, that means stiffness in the legs, and of course, hereditary, that refers to genetic cause. So this is the core features of this condition. And I'd like to briefly remind you of some historical aspects of this disease. So it's been first described in Germany in the late 19th century by Adolf Strumpel in Erlangen, in the south of Germany. So he described a family of actually two brothers that he called hereditary spastic spinal paralysis. So last year I've been to the university there in Erlangen, and I had the chance to take a look at the original publication that I just brought to you in this slide. So this is actually the very first patient that was reported by him as having HSP. And so it's now more than 1 century, and we really learned a lot about this disease in this time frame. Well, I'm now switching gears a little bit to remind you of the key mechanisms behind the HSP. So a very basic concept. And I'd like to remind you of the organization of the motor system. So regardless of the movement that I would like to perform, so like, pointing to something or moving our fingers, whatever we do in terms of voluntary movement, these require the combined action of two neurons. The first one that we call the first motor neuron, as you can see here in this cartoon, is a neuron that actually begins in the cerebral cortex and then moves all the way down to the brainstem and then to the spinal cord. So this is the green one that you can see here. And there is a second neuron that we call the lower motor neuron that leaves the spinal cord and then goes all the way to the skeletal muscles. So our movement in terms of neural basis requires the function of these two neurons. And when we talk about HSP and PLS, for example, we're talking about diseases where the problem is located in the first motor neuron. So this is what we call upper motor neuron diseases. And, this green neuron, this is the main, the basic side of damage and of pathology in this group of diseases. Well, in addition to this main idea, we should remember that the first motor neuron is a pretty long neuron. So it begins in the cortex and it goes all the way down to the end of the spinal cord. So, really long axon. And what we know now from, pathological studies, from, experimental models, is that in HSP, what happens is that the lower portions of this upper motor neuron, this is the region where the damage begins. So it does not begin here in the cortex. It begins in the lower portions of the upper motor neuron. So as you can see here, it comes from the lower portion, and then it goes up, reaching eventually the brain eventually. And as you can see here in these pathological images, so this is the spinal cord from a deceased patient with HSP. And you can appreciate here this, like these white regions here. This is the region where the neurons actually died, and we were able to see these the degeneration, this gliosis, the way we call it. Well, now coming to the classification. So HSP is a pretty heterogeneous group of diseases, and we classify patients into two main groups. So there is the pure HSP group, and there is the complex HSP group. So this is a clinical classification. These actually relies upon clinical features. So what we see when we, for example, talk to patients, and what we see when we perform neurological examination of each individual. So pure HSP patients, they only have spastic paraplegia. There is nothing else, only weak legs and spastic legs. On the other hand, when we talk about complex HSP, we have other neurological manifestations. And these, for example, may include, for example, dementia. This may include, for example, seizures, visual issues. So many different features might be present when we talk about complex HSP. Another interesting point that I'd like to bring here regards the name of the disease. So I'm pretty confident that some of you already have genetic diagnosis. So there might be people here with SPG4, SPG11, whatever. So how is this name defined? So SPG refers to spastic paraplegia gene, and then followed by a number. So in this number, it actually it is defined by the chronological order of gene discovery. So basically, SPG1 was the very first subtype of HSP that has been discovered, then followed by SPG2, 3, and so on. So currently, we have more than 90 subtypes of HSP. So more than 90 different, genes, different regions within our whole genome that we, can have, abnormalities that might cause HSP. And it's interesting to remember, I don't know if it's something usual for you, but I've heard from some of my patients, when they, for example, have the diagnosis of SPG7, they were really afraid that it was more severe or worse than, for example, SPG2 or 3. There is no such relationship. So it basically refers to the timing where the gene was discovered, only that. And here you can see a more visual representation of this genetic variability that is typical of HSP. So you can appreciate here our chromosomes. So you can see 22 autosomal chromosomes in addition to chromosome X and Y, which are the sexual chromosomes. And if you think about spastic paraplegia, we might see genes located in many different regions within our genome. For example, SPG4, the gene is located in chromosome 2, SPG3 in chromosome 14, SPG11 in chromosome 15, and SPG7 in chromosome 16, and for example, SPG1 in chromosome X. So this is just to give you a flavor on the variability that we can have in terms of the genetic background behind this group of diseases. Well, so Norma, would you like to mention anything?
Yes, I've got a question there, Doctor. Do you have those for all 93?
Well, actually, not really, but we can build this, so it's feasible. We could do that definitely, yeah.
That would be an interesting piece of information.
For sure. I think it would be nice to have this kind of picture here, for example, in the web page of the association, for sure.
Well, because where maybe SPG4 or SPG comes into that body, there could be a particular compound or therapy that could be available for that.
Yeah, I think so. But I mean, in addition to the educational aspect of it, so patients can learn where is their the genetic defect. It might also be helpful in terms of trying to find potential therapies. I think so. Well,
Okay.
in CMT, which is a different disease, a peripheral neuropathy, they have this whole, a landscape of genetic abnormalities in their webpage. So we can try to build something similar. I'll be happy to help you with that. So
That would
would
be
be,
great.
yeah,
Thank you very much, sir. I appreciate that.
perfect.
Sorry to interrupt. Let him go ahead and finish his program, but I had a specific question about that. We'll come back and have a Q&A after he's finished with his presentation.
I was going to ask something on that same page.
Okay, go ahead.
Please go ahead. Go ahead.
Where it says I'm SPG4, so where it says
Okay.
24, where are all the other numbers? What are
No, actually, so this is a good point. So I actually did not bring all 93 subtypes here. I
Right.
just decided to bring the most frequent, at least in Brazil.
right?
So this is just a given a flavor of the distribution, but
That's what we were just talking about, Kim, is that he could do that. He could have that available for everybody. So
I
that
know
was my
that I was just wondering what all the other numbers were down below the SPG4. You know, the 24, 22, 16, 14, 12. What do those mean?
no, I think I missed the question. So I mean,
She's
there
asking
are,
the question on that particular line, doctor, where you've got SPG4, it starts off with the red box around 24. Then what are the other numbers that are down below that?
oh yeah. So I mean, I'm not really familiar to all the locations for all subtypes of HSP. So just to look at each one and then to put them here, you know.
Yes. Yes. We'll come back to that, Kim. I see your point.
Yeah. Yeah.
Thank you. Please go ahead, doctor.
Perfect. Perfect. Well, so we're now moving to the actual two main topics of this discussion, and I'm beginning with neuroimaging. So this is something that we've been working really hard in the past few years in our center here, and I'm really, biased because I feel that neuroimaging is a really powerful tool to assist us in the understanding of this disease. I think some of you might remember that when we were first evaluated by the neurologist or by a physician in general, you were ordered to perform neuroimaging. So this is something really usual. We typically do that in the beginning of the investigation. We typically order, brain and also spinal cord imaging. And this is done for one specific reason, which is to exclude alternative diagnosis. For example, MS, for example, tumors, for example, inflammatory conditions or compressions of the spinal cord. So this is part of the initial workup of every single patient that is suspected of having HSP. This is the clinical use. So this is the basics of doing imaging in this kind of clinical setting. But I'm going to talk right now about a different setting, which is the use of advanced techniques. So it relies upon spinal cord imaging, so MRI, the same device, the same scanner, but a pretty different protocol. So much more, detailed, a very high, resolution of the tissue, and this really enables us to perform quite interesting evaluations. For example, we are able to perform separate evaluations of each spinal cord level. So C1, C2, C3 separately, each one. And in addition, we're able to perform separate analysis within the spinal cord. So we can evaluate, for example, the deep portion, which we call the gray matter region of the spinal cord. And we can also evaluate separately regions where the first motor neuron comes from the brain. So it's very precise, it's very specific, and especially it's very quantitative. So this kind of technique, it really offers us the opportunity to detect and to quantify the damage to the first motor neurons. And we've been working on this. I did not actually bring it to this presentation, but we have a pretty, I'd say, interesting data set that we were able to perform on patients with SPG4. So we followed these patients for like 3-4 years, 3 different time points using MRI. And what I can tell you is that it's able to capture disease progression. So even for some patients where the disease was stable, so no clinical change over like 2 years, for example, imaging was able to detect that something was going on, something was really changing. So it's much more sensitive than clinical evaluation only capture this kind of mild progression in this interval, like 1-2 years, for example. And I definitely believe that neuroimaging can help us to understand the disease. For example, it can help us to understand how is the disease progression over time. So which regions of the spinal cord, for example, are damaged, how they're damaged. And it's interesting also to realize that, for example, even in the same family, in the same pedigree, we can see some patients progressing faster, whereas others progress really slowly. So what's the reason? Since they have the same genetic background. So this kind of understanding, it's really, I mean, interesting to approach using, for example, quantitative imaging parameters. And this is something interesting to do. And of course, I think Norma already mentioned to this third point here is that neuroimaging, I think, can definitely be used in clinical trials. So we can take some experience from other diseases, for example, ataxia, which is another genetic disease in the neurology field. We're now beginning to see clinical trials coming out that have been using, for example, imaging as the primary outcome measure to somehow track the effects of some kind of intervention. So I think that imaging might really be helpful. And I'd like, of course, to remind you of this ongoing study that's been done in my centers under my supervision. It's been funded by SP Foundation, which has been wonderful to our group. And this study is actually looking at the spinal cord imaging in 2 genetic subtypes, so SPG7 and SPG11. And it's a longitudinal study, so longitudinal evaluation of these patients. And the idea here is to try to check whether imaging might be able to detect change over time and how it compares to other potential biomarkers in these patients. So hopefully we're gonna have nice data to present to you in next presentations. We're currently, doing well. I think we're reaching a good number of patients, and we should have some interesting data to share hopefully soon. I'm now shifting gears to the other topic. So I'm now discussing a little bit about spasticity and neuromodulation. Well, I think you should be aware of this, but the disease is characterized by 2 key features. So there is some weakness, but there is also this increase in muscle tone that we call spasticity. So this is actually caused by the degeneration of the upper motor neuron. So there is this abnormality in the spinal cord circuitry leading to excessive contraction of the voluntary muscles. So the ultimate consequence is that we have stiff legs and the reflexes become really hyperactive. So this is the main feature of this condition. And we know that there are many potential therapies to address increased muscle tone. For example, some medications, for example, botulinum toxin injections. But for sure, I think one new potential approach is neuromodulation. So neuromodulation is actually a procedure that uses devices to modulate neural activity. And it can be done in the brain, it can be done in the spinal cord. And it's interesting because depending on the approach that we use, we may either stimulate or inhibit neural function. So, for example, when we talk about increased muscle tone, hypertonia, the idea would be to actually not to activate, but actually to inhibit this excessive contraction of these neuronal circuitry. And this can be achieved using different approaches. So you can use, for example, electrical stimuli, for example, some shocks in the brain, on the spinal cord, or you can, for example, use magnetic stimulation to modulate neural function. It's interesting because this can be done invasively or non-invasively. For example, if we remember about Parkinson's disease, it's now pretty standard of care for some patients to undergo, for example, DBS, so deep brain stimulation. So this is a surgical procedure where we locate some tiny electrodes in the deep portions of the brain of these patients, and these electrodes, they begin to stimulate electrically some nuclei in the brain to improve motor function, for example, in Parkinson's disease. So it's interesting for some diseases. It's really, really useful, but it's invasive. So it requires a surgical procedure, anesthesia, and of course, there are some risks. But the other option that we have is non-invasive stimulation. So here you can see, for example, the use of this like 8 coil. So this 8 coil, it's placed just, close to the scalp of the patients, and it produces a pretty intense magnetic field that's able to modulate neural function. So it's much easier to perform, and of course safer to perform in comparison to invasive stimulation. Currently, this is a really, expanding field. There is a lot of research and a lot of, effort in this kind of approach. And as you can see here, for many different situations, this kind of approach is already approved by, the FDA, by the European agencies, and even in other countries. For example, management of Parkinson's disease, for example, management of profound deafness using invasive cochlear electrodes, and also to manage, for example, epilepsy and chronic pain. But for other situations, and here you can see as a future perspective, you can see many, many different diseases where neuromodulation might eventually be helpful. And this is the case of diseases where there is this kind of increased muscle tone, as in HSP, for example. Currently, the amount of available data on neuromodulation in HSP is not really large. Actually, there are a few publications. These publications, they describe different approaches in the patients that were treated. As you can see here, we may employ either non-invasive approach using, for example, surface electrodes, or we may also use invasive procedures with the placement of epidural spinal cord electrodes very, very close to the spinal cord. Some diseases which are, somehow connected to HSP, we have more data. And I think the main example here comes from traumatic spinal cord injury. So patients that had, for example, car crashes, accidents in general, and these patients have been really investigated in terms of the potential use of neuromodulation. So you can see here one example. This is a patient that had non-invasive stimulation, the placement of these, surface electrodes, really, beneath the spinal cord. And then you can see that these patients were evaluated using electrodes placed in the thigh, and also here in the gastrocnemius. And you can basically see that the stimuli that were given to this patient were able to somehow modulate the electrical function of these muscles. Here, I think it's a very, very, compelling example of the benefits, of the potential benefits of neuromodulation. This comes from a publication released, I think, maybe 3 years ago in the New England Journal of Medicine. So this guy here, he was wheelchair bound because he's got pretty severe spinal cord injury after a car accident. And this patient was, treated with invasive neuromodulation. And as you can see here, he was, able to stand still and to walk for some distance using these kind of, device. When it comes to HSP, the amount of data is really small. And I'd like to give you one example from our patients. So this is a young lady that we followed in our service here. So she's got SPG4. She's been followed by a couple of years. And in addition to the typical motor symptoms like, weakness, gait abnormalities, she also developed some chronic pain, which was really bothersome for her. And, we tried to manage this patient using, many different, pain medicine. Did not work at all. And then we decided to move forward and to perform, surgical placement of epidural electrodes. As you can see here, this is the grid, which was placed in the lower portion of the thoracic spinal cord. And it's interesting to realize that, this is the patient. So these, red dots, you can see that she actually improved in terms of the SPRS scale. So she's got improvement over 1 to 2 months with the electrode in the active mode. And this was really different from the typical clinical course that we see in someone with SPG4, where we see progression and worsening of the manifestations. So the patient had a really wonderful result in terms of the pain control. So she's now really well, no pain anymore. But in addition to pain control, the patient also had some, motor benefits. So as you can see here, this is the video before surgery. So we were requiring her to try to move her toes. She was barely able to move them. And here you can see her after the placement of the electrodes. I think it's easy to see some improvement. So she's able now to move the toes and also perform dorsiflexion of the foot. So it's really initial. This is a case report. We now have a second patient, very similar setting. So she underwent placement of invasive electrodes to manage pain, and we had surprisingly positive results also in terms of motor function. And this was the main reason why we decided to move forward and to design a clinical trial, which is currently going on. So this is a collaboration between my center and other center here in Brazil, the University of São Paulo. This is funded by a local Brazilian research funding agency, so FAPESP. And this is the main, the overall design of the clinical trial. So this is a crossover design. So patients shall undergo active stimulation and then a group of placebo, and then we're going to switch the arms of the clinical trial. And we hope to have data by the end of the year so that we can really evaluate whether this might be helpful in terms of motor function of patients with HSP. So hopefully we're going to have data soon, and we will be happy to share these data with you as soon as we have the full data set and analysis done. So to finish, I'm now coming to my last slides. I'd like to bring a brief summary. So neuroimaging, I think it's a really powerful technique. It can definitely help us to understand disease. And the main target definitely, I think, is spinal cord MRI, using this kind of advanced techniques that enables us to perform quantification and evaluation of specific regions within the spinal. Regarding neuromodulation, I think we've seen that it's also interesting. I think it has some potential to improve, increase in muscle tone, and we're now moving forward with this clinical trial and hope we have more robust data to bring to you and to really evaluate whether it's a potential treatment for HSP. This is my last slide, I think. So this is my group from Brazil. And of course, I'd like to thank so much our funding agencies. And this, of course, includes SP Foundation. I'm really helpful for the support that you have given us recently. So I finished now, and I'll be happy to take any questions you have. I'll be happy to address those.
That is very informative, Doctor, and I thank you so very much for going through all of that information. And I know I have a ton of questions that I myself am interested in, but there's a bunch over here in the chat. So let me get over here and get several of these out of the chat first, and then we can come back to the screen. So hang on, Gina, and we'll get you back in line here. So I don't know if you could see, is there a dominant SPG across all of the patients?
Yeah. You mean the genetic subtype? So I'll give you an overview of my situation here in Brazil. So we currently follow close to 350 families with HSP in my center. By far, the most frequent is SPG4. So it accounts for perhaps like 40% of all patients are SPG4. And then followed by, in my center, for example, it's followed by SPG 7, 11, 76. I think these are the most frequent in our center here.
That is wonderful. Thank you. So does the MRI of the spine eventually start showing lesions for a person who was always told the MRI was normal, specifically SPG4?
Yeah, this is a good point. And the brief answer is yes. So what is the reason for this?
So it shows
So the point is that when we do MRI on a clinical setting, what is the idea? So we're going to have a physician, like a radiologist, is going to look over the image to check whether there is some gross lesion, so like compression, inflammation, whatever. But so it's not able to see any microstructural changes. So this is the point. When we use this kind of advanced technique, you were able to perform really, I mean, detailed evaluations, quantification of, for example, diffusivity parameters, volumetry, for example, morphometry of the spinal cord. And this kind of technique is able to detect changes. And as I mentioned to you, we just finished this large survey in our SPG4 cohort, and there are lesions in the spinal cord that we can definitely detect using this kind of protocol, and I think it's really interesting. So you need to look at the data the right way. So if you just look at the data using this kind of a general approach, visual evaluation only, you're not going to see anything at all. But if you move forward and change it to this kind of more, quantitative, advanced approach, you are definitely able to see, changes in the spinal cord.
That is a golden answer. Thank you so very much. I think that is so very important. So on down here a little further, is neuromodulation able to be used in an individual with complex SPG11 and bedridden?
Wow, this is a good point. So I think so. I think it might be helpful, but of course, I think we should initially look at the patient and to see his clinical situation and this clinical phenotype. SPG11 is interesting because the phenotype changes over time. So in the beginning of the disease, there is a lot of increased muscle tone, really, really spastic. But after some years, it's interesting, it becomes to be less spastic and more like a flaccid phenotype, because there is the appearance of lower motor neuron involvement in the later stages of the disease. So it really depends on the phenotype, on the clinical situation. I think it might be helpful, but I would definitely recommend, a clinical evaluation to check whether, it's really the case to use it.
Thank you. Can we get a cheat sheet, like a fact sheet of some of those abbreviations that was used on the approved and future uses of the neuromodulation?
So in the slide, you mean? So there are many abbreviations. I can share the slides, and I can include in the slides the meaning of each abbreviation. So would that be okay?
Yes, that would be wonderful. So if you can do
Okay.
that, we'll get that uploaded. We'll also email it out in an e-blast to all those people that have registered for this SPF talks. We'll get that out. That's a great question.
I'll be happy to do that. So I'll work on this slide, and I can include the definition of each abbreviation, so it's going to be easier for you to understand what's going on there.
I know you're working with neuromodulations, but would you happen to know if there are publications about neuromodulation for people that have PLS?
No, this is a good question. I think there are some publications out there, but I think mostly, case reports, small series, nothing really, robust in terms of a clinical trial or a large data set. So, there is something there, but nothing really robust, I think.
Well, you mentioned that you see 350 patients that have HSP.
Yeah.
Are you seeing any patients with PLS?
I do see also with PLS.
You do? So you got PLS and HSP in the 350 number?
Not really. So because I have two clinics, so I have one clinic only for HSP, so it's just that. PLS I see in other clinic, so it's really separate. I do have perhaps like maybe 15 or so PLS patients, so the number is not that big, but I do have some patients also.
Well, we would like to do an outreach for them as well. So, if we could maybe do a presentation that would be included.
For sure, yeah, I'll be happy to.
Yeah, we would love to do that as well. That's good. That's a very good question. Thank you there. So how do you determine the correct placement on the spine of the electrodes for neuromodulation?
Excellent question. So we actually struggled a little bit with that question. So we actually did a pilot study initially, and we actually tried to try different, portions of the spinal cord. And I think we now have the right answer. So we initially thought it might be more interesting to approach upper portions of the spinal cord. We now changed the concept. We now went down. We're now actually trying to stimulate the very, very lower portion of the spinal cord, because we feel that the most probable region where neuromodulation is acting is not the spinal cord, is actually the spinal roots, especially the dorsal roots. So it would be a kind of a functional rhizotomy, So this is different, for example, from the invasive approach. So in the invasive approach, we feel that you are more, more probable to stimulate the spinal cord per se. But using the non-invasive approach, we might reach the roots indeed. So we changed this approach, and this is the way we're gonna move forward with the clinical trial. And we have some data now using clinical neurophysiology, using this lower portion approach, and we're able to see some beneficial effects in the clinical neurophysiology evaluation of the rage reflex. So very initial data, but this is our perspective right now. So lower portion of the spinal cord.
Thank you so much, doctor. Have you gotten any experience with this cynic neural sleeve? Is that considered neuromodulation therapy?
Well,
Mary, you're using that. Do you want to speak that out? I'm sure I pronounced it incorrectly.
Norma,
hi.
Yeah.
Yeah, it's been approved for folks with MS. And so there's basically, I have 24 electrodes on the sleeve that I wear on my leg. And so it'll stimulation to my right shin to lift my foot, and then the right calf to help the heel go down. And so it uses all these 24 electrodes to help people walk, but it's mainly been, like I said, approved for MS, and I found some benefit, not a lot, for HSP, I have SPG4. So, but I'm wondering if somebody like them, they're kind of a startup company, and if they might be working on something more along the lines of the spinal stimulation. I don't know.
Yeah, I do not have experience with this specific, device or approach, but the concept behind it is actually neuromodulation. So as soon as as far as I understood from your talk, I think we're now talking about a stimulation of muscles, actually. So this is a kind of a peripheral neuromodulation approach, which makes a lot of sense, especially for patients where we have also, relevant weakness in some muscles. So I think it might be also interesting, but I don't know. If I were supposed to choose one, I would target the spinal cord, because I think this is where the main, site of damage is there. So
how do you see, doctor, people gaining access to having that available for themselves? Is that available in the market? Do we come into your office? I mean, right now it's in clinical trial, right? You're doing clinical trial right now in your office with a number of patients. So what do you see as far as the timing of having that available for people on the market?
Well, Norma, I'm aware that other groups are also working in this topic. So there are some groups in Europe also attempting to evaluate neuromodulation of the spinal cord. Some of them using electrical stimulation. Others are, as we are doing here, using TMS, so magnetic stimulation. I think we might have by the end of the year some results coming out. So from our group and from others, I think. And regarding like a kind of a self use of neuromodulation, I think it might be feasible because it's not really complicated. But the main concern regards the cost of the device. So, for example, with TMS, it's an expensive device, so it would be hard for someone to purchase and to have it at home. But there is another approach using electrical stimulation, which is far more accessible, not really expensive, And this is more suitable for this kind of at home and self done procedure. So, I mean,
anything to help relieve pain and suffering and all the issues that these people, that we're all living with and we're all fighting. So if there's any moment of a relief that some people could get, this seems like a no-brainer.
Yeah.
Going back over to the questions, what type of therapies would you recommend for a complex SPG 11 that is in the bed and is starting to lose function in the hands? See, I mean, gosh, we got to come up with something.
Yeah, definitely. So this is a good point. So I might give some insights on that point. Well, my experience with SPG11 is that many of my patients with SPG11, they have this initial spastic phenotype that later on switches to this more flaccid or peripheral phenotype. And when this happens, this is the timing where I begin to see more weakness, especially distal weakness, wasting of the hands. And I anticipate this might be happening to this specific patient. So the management of this peripheral aspect of the disease is, really challenging because we don't have actually many options. But what I would perhaps try would be to use dopaminergic agents. So we published a paper some years ago in SPG11, even in patients without clinically evident Parkinsonism, using DET scans in these patients. I think at the time, we're able to scan perhaps like 30 patients or so. And we're surprised to see that even patients without clinical Parkinsonism, there was remarkable abnormality in DET scans. So since we published that study, we've been looking more carefully at Parkinsonian features, and we've been also more enthusiastic about at least trying to give them like levodopa or that kind of medication. And surprisingly, we got some patients with pretty nice responses. So in this scenario where we don't have many options, perhaps that would be an option to manage the situation. In addition, of course, to rehabilitation, to orthosis, and all the typical supportive measures that we recommend.
Gosh, that's amazing. Thank you so much for those questions. That is just absolutely amazing. Okay, I want to stop going over into the chat, and I'm going to come over now to Gina. So if you guys, I'm going to come back to the chat, but if you guys have got questions, I'd rather you come on screen and ask those in your voice, if you will. I think that's more of an impact for him to understand who you are. But we'll come back to get the last questions here because we're going to run out of time. Gina, go ahead, please.
All right. You did answer, I think, a little bit with this one question, and that was about the positioning of the neuromodulation. Because I was curious about that, because I know you have the back foot pump, which I know that gets inserted in the lumbar region. So I was wondering if that was, because you said you're doing it thoracic area, and I go, it's kind of strange that you did thoracic, and then we have the back foot pump, and it's inserted in the lumbar. So I didn't know, if that was going to be.
So is there a conflict there, Dave? Yeah. Doctor, would there be a conflict or a problem having both of those in the spinal cord?
Well, I don't think so. I mean, the main point is that, it's really different if you think about invasive and non-invasive. So this is an important point. What we're able to look so far is that if you use non-invasive, you're not really able to reach a very deep located region. So the bones within that region, it's really, hard for the stimuli to get deep into the spinal cord. So from our experiences here, we feel that what we're able to get is actually to modulate the function of the roots of the spinal cord, which are more like peripheral. And it's interesting because if you're able to reach sensory roots, you're able to modulate the circuitry within the spinal cord. So this is the main reason why we felt it would be more interesting to reach the lower portions and actually try to focus really on the roots rather than on trying to really modulate the spinal cord. I think this is really different from what we see using invasive electrodes, where we're able to reach the spinal cord really, really real closely.
So you have to use that neuromodulation in place of a pump? Would it work in place of a pump?
No. I mean, the approach we're using here, there are other approaches in the
Mhm.
literature and in other groups, but what we do here is that we actually use these like this 8 coil. So this is the TMS coil. We place it in this region here. It
Mhm.
typically takes like 35 minutes or 40 minutes of continuous stimulation, and patients come like 1 hour or 45 minutes for 5 consecutive days. And this is the protocol in this pilot study. It seems to be sufficient to have some long-lasting effects. And then patients would need to repeat the protocol again on a regular basis. The interval is not clear so far. I think it might last up to like maybe 2 months or so, but it's definitely going to require repeated application. So it's not really something that we just place there and keep it there. It's not like a baclofen pump, for example. It's different.
Oh,
You just go there, have the procedure, and then come back home, and this is the way we're thinking about that.
okay.
Kind of like going to a massage therapist or a chiropractic care. You're going in for a particular stimulation, and then you go home and live life, and then go back the next day.
Oh,
in
okay.
this particular trial, this
Yeah.
particular trial. But so he's looking at the long-term effect. How long does one of those treatments last? So
Yeah.
thank you, Gina, for your question.
I do have one more question quick.
Wait a minute, we got to go on. We got to go on, Gina.
Okay.
We'll come back. Go ahead,
Okay.
Philip, please.
Hello, can you hear me?
Yeah.
Yes.
Yeah, thank you for your time. I had a quick question. So right now I have pretty good function in my legs. I'm dealing with some spasticity, deal with a lot of fasciculations. So I was considering using a TENS device with the concept of the neuromodulation, but I don't know if that would be a good idea considering the fact that I have chronic fasciculations throughout my body. I deal with a lot of chronic pain, but my function currently isn't too terrible yet.
So Philip, would you mind? What's your genetic subtype?
SPG4.
4. Okay. Well, TENS is another, neuromodulation approach for sure. It's, of course, the target is different. So it's more like a peripheral target, especially peripheral sensory neurons. I think it might be really helpful for pain management. And I'm not really concerned it might worsen, for example, fasciculations. I think, I mean, if it's beneficial for your pain relief, I think you should keep using it. I don't think it's a major problem. And unless you have frequent cramps or not.
The pain is more nerve pain. I don't deal with a lot of cramps. I just deal with the twitching and a lot of nerve pain, and then I get like a deep soreness in my calf muscles.
Okay. Well, I mean, if I understood correctly, I think your concern would be if TENS would eventually worsen fasciculations. I don't think this is the case, so I think it would be good to use it if it's really helpful for your pain relief.
Yeah, I haven't tried it yet, but I really appreciate your response. Thank you so much.
Perfect.
Thank you very much, Philip. Mary Schultz, go right ahead, dear. Kayla, you're next. Mary Bridget Schultz.
Yeah, I was trying to figure out how to get myself off mute. My question you might not be able to answer about the availability of neuromodulation. Sounds like an exciting potential therapy. How available is it, including the cost?
Well, I think I didn't actually got the question, but I think it regards the availability of neuromodulation. Is that the question?
Yes.
Yes, and the cost.
And the cost. Yeah, good point. So, well, at least here in Brazil, it's an experimental procedure so far. So it's not covered by insurance companies or the public system at all. So this is one of the reasons I think we should have more robust data to get this kind of formal approval. And in this case, it would be help because we could definitely get reimbursed for this kind of procedure. Currently, if you use TMS, the main problem regards the cost of the device, which is not really, I mean, cheap. So it's really expensive. I don't think it's something that someone could purchase as an individual. So this is for an institution or for a clinic. But once we have the device, so the cost would not be really high. But so far in Brazil, it's only covered as a particular procedure, so you need to pay out of the pocket. It's not cheap here in Brazil, and I think we should provide data. We should, come out with robust evidence favoring its use, because using with this kind of information, we can eventually come up to FDA or other agencies and finally get something to be covered. This is the way I think about this procedure.
Thank you so very much. That is something that, obviously you guys, we're on the cutting edge of finding out about this information from this clinical trial. And we're all like just wanting to drink in every bit of the information and find out, how can we get it? What can I do? We want to be a part of that. But what he just said is we need to find out how FDA can make this available. Isn't that what you said? We're getting ready in October to have an annual conference that we're taking to Washington, D.C., where we are going to be talking to NIH, FDA, CDC, and we're going to be talking about regulatory science and how we need them to be making things available for us when you guys are, making these discoveries. So it's going to be really important for us to be able to maybe have another conversation with you and to help us to understand, what are the things that we're dealing with in America that are regulatory issues for you guys to get these things for us. And obviously we know money's always the big deal. So hang on, we got a couple of more questions. Kayla, please go ahead. You got a question?
Hi. So I understand why you, most of the research is in SPG4, but is this overall treatment for HSP?
I think so. Kila, the idea here, neuromodulation is pretty different from some genetic approach. So if you think about gene therapy, for example, there would be genotype specific. So there is one for SPG4, 5, 6, and so on. But if we're thinking about neuromodulation, I think the idea behind that would be basically to improve the tone of the patient. So, in case you have a genotype that we have, troublesome spasticity, so it might be amenable to treatment. So I don't think there'd be an exclusion for other non-SPG4 genotypes. Not at all. I think it's going to be potentially for all other subtypes. Yep.
Because I feel like the goal is to find a cure or treatment for HSP, not just specific types.
Because
go ahead, doctor.
No, just a quick comment. So my view about this approach, like using neuromodulation, this is just a way to improve quality of life, perhaps to gain some function. And this is something that's going to be helpful in the meantime, up to the appearance of like gene therapies, like the appearance of ASOs or anything really that targets the genetic defect behind each HSP subtype. We know it might take some time up to have this kind of genetic approach. So in the meantime, we should definitely try to figure out other ways to gain time to improve patients' quality of life, function. So this is the way I think about neuromodulation. It's not a cure, not at all, but it might be helpful.
It's an improvement.
Yeah.
Well, it's like everything else. We've got this that's happening to our bodies while it is progressing. We do not need to stop moving. We do not need to stop. I know some of us can't get up and go, but there is something that you can keep doing, whether it's picking up, soda cans and using your arms, or, trying to do some chair yoga, doing the therapies, doing the massage therapies, the chiropractic cares, all of those things. This is another tool in the toolkit. So, if that young man got up and was walking from a wheelchair, right?
Mm-hmm. Yeah, exactly.
A young man that was in a wheelchair, and with his constant using of this device, he's up walking.
Yeah.
So, the possibilities are there, you guys. But what you've got to do is to keep yourself physically fit as much as possible. And, it's going to be a challenge, for sure. I'm not trying to minimize that in any way, but you've got to stay positive, and you've got to find ways to make your body stronger and capable, because if there is a medication that comes out that stops that progression, you're going to probably want to use these devices to get your bodies back to moving. I mean, if that young man can get up out of the wheelchair and he's walking across that floor, that to me is remarkable opportunities in technology that we all need to be looking at. Doctor, do you know about any of these kind of neuromodulation services or opportunities in the United States?
Well, Norma, not really. So I'm aware of some groups working in Germany. In the West, to be honest, not really. But I might reach some of my colleagues working on HSP, and I can ask them about this. So I can give you some feedback later on. But so far, I'm not aware of any group working on this topic.
Well, you may or may not know this, and I certainly want to tell you this. And you guys were running out of time, and I apologize that we're running out of time. But we have funded the Spastic Paraplegia Centers of Excellence Network, the SP-CERN, and we want to, be inclusive of other places across the world that are also working with things that are related to biomarkers and things that are related to what you're talking about. We might need to kind of open that conversation up and have a broader opportunity to kind of bring you guys into that spastic paraplegia.
No, I mean, that would be fantastic. So I'd be more than happy. I think, I mean, we're really, I mean, out of the mainstream in Brazil, but I think we have really a pretty large cohort to have, some experience in leading these clinical trials. And I mean, I think we can help in the construction of these, evidence and.
Well, after you get finished with everything that you've got to do here in this next 2 or 3 weeks or a month, then send me an email that let's kind of open up that door and see what we need to do to get that door opened up. And
I'll be happy.
You've got statistics and abilities of 350 HSP and PLS people. So, we need to be trying to find ways, to work. And that's one of the things that I had said earlier in the other session this afternoon is that we are working with about 15, 16, 17 countries across the nation, across the world that are coming together to talk about World Day for HSP and PLS. And I think sometimes, our own membership doesn't understand that we help to fund this research. And so we want to make sure that it's available for all the people in Brazil and all the people in America. And we need to figure out how to get you here and to get that information available and more flowing over into what's going on. So your clinical trial and the information coming from your clinical trial is going to be very important. I mean, it's like golden. So I really appreciate your being here. Gina, I'm going to let you probably have the last question. So please be quick. We might squeeze one more.
This is kind of pertaining to what Kim initially had asked when I first came on, and that's about that chart, the chromosome chart. Okay. And I want to know, what is the deal with the P at the top and the Q at the bottom?
Oh, good question.
I just vaguely kind of understand it.
Yeah, so every chromosome is actually split. I mean, there are 2 regions within each chromosome. So the P stands for PT, so small part of the chromosome, and the Q, this comes from French, would be the large portion of the chromosome.
Okay, my doctor's saying that to shorten along. Okay, yeah.
So whenever we find a gene, so we initially map it to the region. So when you say, for example, SPG4, it maps to 2P, so it's in the small portion of chromosome 2, and then 2P, for example, 12.2. So this is the small portion within the small portion of the chromosome 2. So this is a kind of a genomic nomenclature that we use to, to describe the precise location of that gene within the chromosome. Because, for example, each chromosome has more than like 15 million base pairs. So it's huge.
Yeah.
Then you need to use this kind of...
it's kind of the address.
Yeah, exactly. Yeah.
Thank you.
Thank you,
Anybody
sir.
have any parting words, Selena? You got a parting word?
Oh, just thank you so much for everything. Like the Brazilian people that speak Portuguese are very happy to learn else about everything that Dr. Marcondes said today. And thank you so much, Number, for the opportunity to open for two languages the same day.
This is really great. Okay.